So epidemiology, is really about two things. So one is in medicine and in healthcare, in public health, we need to know how to practice better clinical medicine and how to do better public health. And for both of these, whether it's individual patient care or public health, we need evidence on or knowledge on what we call three fundamental types of knowing. Knowing, the word gnosis means to know. One is called diagnosis, second is etiognosis, third is prognosis, right? Diagnosis, as the word implies, is really about detecting diseases or screening for diseases. Second, etiognosis is really about knowing what is the cause of a certain condition or a disorder. Prognosis is what is the natural history or outcome of that particular disease, and can it be altered by treating it, right, or preventing it. And I like the way this is classified because everything in human medicine and public health does fall into these broad buckets, and the study designs we talk about also mirror or match them. So, and you can see here, I've given you three types of questions, all relating to the COVID pandemic, which maps nicely to what we're talking about. Firstly, we're all wondering how COVID is diagnosed, right? How accurate are the tests? I asked you a question in the quiz about false positives and false negatives. That's exactly what I'm talking about. How do you know if a test is negative that the test isn't wrong? The patient actually has an infection, right? How do we detect infection versus disease? So these are all diagnostic questions, okay? And we will have an entire lecture on how we, if we were to design a diagnostic study, would do it and how we would interpret test performance characteristics such as sensitivity, specificity, predictive values, so on and so forth. The next issue is what is the etiology of COVID-19? Who is likely to get it? Who is likely to die of it? Who's likely to have mild versus severe illness? What are the risk factors for ending up in the ICU? These are all etiological questions in COVID-19. And then there are therapeutic and prognostic questions. What is the natural history? What is the case fatality rate? Can we prevent COVID with the new vaccine? Is there an effective treatment for COVID? How do we know remdesivir works or not? How do we know chloroquine works or not? These are all therapeutic questions. And beyond COVID, it doesn't matter what disease area you cover, you are dealing with these sorts of questions. For example, does air pollution increase the risk of mortality among people living with tuberculosis in New Delhi? That's a very important question. In fact, that is Lina's PhD thesis topic, right? So each of these is a valid question and it deserves a strong epidemiological study to answer them. Now, how do we answer these sorts of questions that we've just posed? And the answer is EPI. Epidemiology is the only realistic method that we know in science which can help us get towards the truth. It doesn't guarantee that we're going to get the truth, but it is our only shot at even coming close to answering the sorts of questions that we would pose in our daily life. Now, what is epidemiology? There are multiple definitions of epidemiology. The one that I have highlighted in red is my favorite. It's basically the application of the scientific method to health research, right? Just as you would use a scientific method to study a physics problem or a chemistry problem or a fundamental biology problem, those of us working in medicine and public health use the principles of scientific method to answer clinical or public health questions. And it is the scientific method, or by following the scientific method, that we have any hopes of not going astray. If we believed in our personal experience or anecdotes, we would always run the risk of being completely biased in the way we study things and come up with completely misleading conclusions. Epidemiology, the principles of epidemiology, is what we hope protects us from making some serious flaws because nature tries to kind of trick us, right? We were always worried about what we are getting wrong in epidemiology, and we try very hard to put checks and balances to make sure we are not deluded in the way we are thinking about things, right? I'll give you a great example of how fundamentally flawed, human clinical anecdotal experience can be. When I was practicing medicine, I asked a doctor about using chloramphenicol, I think, for typhoid fever. And the doctor said, I gave chloramphenicol to a patient, and that patient almost died. So I never use chloramphenicol, right? Now, this is a fatally flawed way of thinking because one experience with one patient doesn't tell you about the thousand other patients who may have received the drug and done quite well with it, right? You need aggregate data to make sense. You need sufficient numbers and you need a properly designed study which reduces bias in order to get you close to the truth on whether chloramphenicol can or cannot be given for typhoid, right? So this definition of applying scientific method to health research is a particularly meaningful one for me. And now, of the three types of gnosis that I spoke about, diagnosis, etiognosis, and prognosis, etiognosis or causality is the thing that epidemiologists are famous for. If you say, what is it that epidemiology really cares about, then it is to establish a causal link or lack of a causal link between some exposure factor and some outcome. For example, the exposure factor could be, does smoking increase or protect you from COVID-19 infection or disease, right? Smoking is an exposure factor. Outcome is confirmed COVID-19. Or BCG vaccine is an exposure factor. Preventing COVID deaths is the outcome. Epidemiologists are always obsessed between what's the exposure we are studying, could be more than one, and what's the outcome we are studying. Defining the exposure, defining the outcome, and assessing the link between them is pretty much bread and butter for what we do. If you look at a typical epidemiology journal, virtually every paper will say association between this exposure and that outcome. This exposure, that outcome. This is all we do, right? Does mobile phones increase the risk of brain tumors? That's it. The classic epi problem. This is all we do. This is the kind of research we do day in and day out. Now, causal claims that something is linked to something is all over this pandemic. In fact, the noise level is so incredible in this pandemic that it frustrates the hell out of epidemiologists like me because these sorts of correlations, and these are all headlines from news that I've thrown there, right? Vitamin D protects you from COVID 19. BCG will immunize you against COVID 19. Sunlight is associated with COVID 19. Smokers are less likely to fall ill. Zinc can be a big deal. I mean, it's absolute madness, the kind of correlations that are being floated around. And very few of them at this point, I can tell you, are backed by any serious, worthwhile epidemiological evidence. So it's actually dangerous to have this kind of causal links in the media by completely uncritical journalists and by researchers who are trying to push their research findings too early without even thinking through causal inference the way we would do in epidemiology. Even without COVID, to be honest, snake oil has always been peddled, right? If you look at the number of crazy products thrown around for cancer, for example, today it's green tea protects you from cancer. Tomorrow, coconut oil prevents you from having liver disease. It's an endless stream of these sorts of issues that epidemiologists are always worried about. And we always take these things with a huge pinch of salt unless it is truly well established with multiple research studies using causal inference principles that you will learn here. We would never buy something is causally associated with something else. It's a huge deal for us in epi to make a causal claim. And because these causal claims are so widely thrown around in the media, and because epi studies sometimes genuinely contradict each other, it results in this maddening problem of conflicting causal claims in the same newspaper separated by a few days or months. For example, today coffee protects you from colon cancer. Tomorrow coffee is linked with colon cancer. And an average coffee drinker is wondering what the hell is going on here. Do I drink coffee or not? Right? So this is just one example. I mean, look here. Drinking alcohol is linked with dementia, and then somebody publishes another story that alcohol could protect you from dementia. Now, what is somebody to do in this situation? Right? Same thing. Today there is a gene that is associated with depression. Tomorrow that gene is no longer associated with depression. And this cartoon is a very famous spoof on the New England Journal of Medicine, right? From the New England Journal of Panic Inducing Gobbledygook, right? Total random medical news of today. You spin a wheel and, smoking. This would apply beautifully to COVID 19. You spin a wheel, you pick smoking, you pick vitamin D, you pick whatever you want, and you pick COVID. And then in adults, in children, in rats, in humans, in mice, you basically got your media release ready to go. Okay. This is the kind of, and this news cycle is also a beautiful cartoon, right? Everything about this cartoon is true right now in this pandemic. Researchers like me are throwing out preprints that something is correlated with something. We try hard to at least explain in our paper all the caveats and the cautions and the limitations of our study. Then our university press release sanitizes it, blows it up, makes it look much more attractive because they want the media to highlight the university. And by the time you guys get involved, you ditch all the cautions and you simplify it for your public, and then you have this fancy splash headline that vitamin D cures you from COVID-19, and the nightly news it takes it even further and says everybody should get vitamin D now, and the local politician and our grandmas are confused on whether they're supposed to take vitamin D or not. And this news cycle was already bad before COVID. Now it's happening at light speed, right? Everything is fast tracked, everything is media, everything is breaking news, and everything is confusing as hell, right? So that's I think, one of the biggest problems, that the research is of variable quality. There are too many causal claims made in the scientific literature, and then those sorts of potentially biased, inconclusive, overhyped studies, along with the media reporting around it, results in tremendous chaos that we are seeing in this particular crisis. So, how do we, as epidemiologists, address causal claims? Firstly, I think we all, any epidemiologist, will be very or should be very humble that even if we do a study, and even if the study is done well, it is still possible that we've ended up with a biased result or an invalid result, right? And common sense is often completely inadequate sometimes to even understand whether we made an error or not. And I'm going to give you some interesting examples. Causality, although we as children grow up, testing different things to kind of make causal claims in our head, right? We turn the light switch on and off and on and off and on and off. And then we slowly get to learn that flipping the switch should turn the light on or off, right? So we do kind of learn causality more by intuition and by trial and error. But unfortunately, to answer real world health questions, that kind of intuition or common sense is simply not adequate. You need a rigorously trained mind to be able to even anticipate what the problems are. And here are some examples. When I was a resident in India, somebody did a study which looked at wound infections among in a surgical center, and they basically looked to see what is the total number of proportion of patients who ended up with a wound infection, that is pus in the wound, post surgery. And when they looked at various categories of surgeons, they found that the wound infection rates were highest among the most senior surgeons. Okay, highest among the most senior surgeons. And so a resident came to me and asked me, "Sir, what do you think? Should I publish it?" So I said, do you want to get fired by your professors, right? Because the senior surgeons having a higher rate of wound infection is a very naive estimate, right? The data might be correct. The data is correct, but the interpretation completely changes. So I asked him a simple question. Compared to the junior most surgeons, who do you think the senior most surgeons are going to be operating upon? So he said, we call the senior surgeons only when the patient is really sick or if it's a very complicated case. I said, there you go. If the senior surgeons are operating on the sickest people with most complications, well, that's the group that will end up with a high rate of wound infection. So the issue here that the naive understanding does not capture is that senior surgeons select the sickest people who are most likely to have complications. That is a selection problem, which if you do not anticipate and address that, you're going to make a very wrong conclusion that senior surgeons are incompetent and that'll get you fired. Okay, so that's a simple example. So here, the reason why senior surgeons pick some people to operate and not others is critical, and that is associated with disease severity. Disease severity modulates the results that we see. Here is another example. This was a study done in Sevagram by some of my friends there. They get lots of snake bites in a rural population in Maharashtra, and they found that mortality was highest after a snake bite among those who had the highest doses of anti-snake venom. Okay, after a snake bite, if you look to see who died and lived, mortality was highest among those who got the highest doses of anti-snake venom. Now, again, a naive understanding here will say, oh my God, snake bite given in huge doses might actually kill someone with snake bites. The reality is the exact opposite. Why would you pump someone with anti-snake venom? Because they're about to die, right? There are many snake bites which are completely non-poisonous and actually will not need anti-snake venom. It's only when you see someone deteriorating and you know it's a poisonous snake, you pump the person with anti-snake venom in a last-ditch effort to reduce the amount of toxin in the body. And so here again, like the previous example, there is something called disease severity, and there is a problem in epidemiology called confounding by indication, right? Because anti-snake venom is indicated in large quantities, that is associated with underlying disease severity or risk, and that puts them at higher risk of mortality. Again, you need to thoughtfully do these studies, otherwise you will make diametrically opposite conclusions than what the data are actually telling you to do. Okay, so confounding is a big deal in this particular problem, right? Here is another study, a real headline. Dog owners may have a lower risk of dying from heart attacks according to a study, right? So take a look at this. Exposure is ownership of dogs. So that's my dog, okay? And yes, because of her, I walk a lot. Okay, so she forces me to take her on walks in the morning, in the evening. So you might say dog ownership might protect me from heart attack, and I hope that's true. But this is a very naive headline, right? Question to ask here is, if I have a dog and if I have the time to walk the dog, am I already doing other things that will protect me from heart attack? Firstly, am I reasonably well off? I can afford a dog. I can afford to walk the dog. I may be doing other things. For example, if I'm a dog owner, it's possible that I don't smoke. It's possible that I am physically active even otherwise. I may be doing a whole bunch of other things that tracks with dog ownership. So the dog ownership is one exposure, but the dog ownership invariably pulls with it a whole bunch of other variables or traits that may be even more important in protecting me from heart attacks than the dog ownership itself. So we need to always ask, is dog ownership a surrogate for something that is deeper and more meaningful? It is merely a socioeconomic indicator. Is it an indicator of time and leisure? Is it an indicator of other healthy behaviors? And that's why we need to get this a lot. Later on, you will see a fantastic example that women who take hormone replacement therapy pills in the observational studies were found to have a lower risk of heart disease. Turns out that women who take hormone replacement therapy are wealthier and are non-smokers, likely to be lean, likely to be exercising, likely to be doing a whole bunch of other things that protected them from heart disease. And when randomized trials were done on hormone replacement therapy and heart disease, randomized trials actually showed a higher risk of heart disease and mortality among those women who took HRT. So the observational studies were seriously flawed because of a whole series of biases. Women who take HRT and stay on HRT are fundamentally different from women who never get onto HRT and do not stay on HRT. And if we don't adjust for that selection bias and confounding, we're going to be left with very misleading conclusions, which is exactly what happened with observational study after observational study showing protection while randomized trials showed the opposite. Okay. Now, this is a beautiful illustration, one of my favorites. It's from a paper by Malcolm McClure and colleagues published many years ago. So basically, he's saying, imagine you are looking for a causal relationship between some exposure and some outcome. Okay. For the sake of discussion, let's say the association we really want to know is smoking, and the outcome we want to know is COVID-19, right? Because there's some study showing that smoking may actually protect against COVID-19, okay? While some studies show that tobacco smoking increases the risk of COVID-19 mortality, okay? Now we're confused and we basically want to know what is the fundamental truth here. And there's only one truth, and we will find it eventually. Right now, we don't know. Okay, there's too much noise, not enough research, lots of biased research. But that's a beautiful, important causal link that we are chasing in epidemiology. Does tobacco smoking protect or increase the risk of COVID-19? Okay, and it's a very long road to get to that causal inference. I promise you, it will not happen this month, next month, or even a year. That much amount of literature needs to percolate, different study designs, triangulating it, reducing bias, and you will see in a bit how long this whole process to making that causal inference could look like. For now, you see here, there is something called risk ratio causal. Okay, risk ratio causal is the truth. Let's say, for the sake of discussion, the true risk ratio is tobacco smoking increases the risk of COVID-19 by a factor of 2. Smokers have a twofold higher risk of ending with severe COVID-19 compared to never smokers. Okay, let's say for the sake of discussion, that's the truth. I don't know the truth. I'm just throwing it out there. Okay, that risk ratio causal is 2, and it has to be 2 in the sense that that is the truth. And now you ask me, how the hell does anybody in the world know the truth? The honest answer is nobody can ever know what the truth is. But if enough studies, well-designed studies, converge somewhere around true, then eventually in epidemiology, we will have a consensus that by average is the truth. Smoking increases the risk by twofold. Okay. Now, that's the truth we are after. Okay. That's the causal effect. Okay. Now, Malcolm McClure is asking us to use this episcope. He's saying, think of it as a long telescope through which you're peering at the true causal effect somewhere far away in the night sky. Okay. When you look at a distant object in the night sky, let's say another planet, Saturn, or a comet or whatever, you want to see a clear image of what you're looking at. Okay. Here, the clearest image we want to see is a causal risk ratio of 2.0, right? If that's the truth, we want to detect that with our epidemiological research with absolute clarity and precisely. Okay. We don't want the image to be blurred. If the truth is 2, you want to be as close to 2 as possible. But in reality, just like when we peer through a telescope, we will never see the image without it being blurred. Why? Because there is distortions in the atmosphere, there's distortions because of pollution, and there's distortion because the lens is not perfect. There's a whole bunch of reasons why the image you see might be fuzzy or blurred or completely different from the truth, right? In the same vein, when we look through an episcope, trying to detect that causal risk ratio of 2, you will first encounter something called random error. Random error is 100% guaranteed in every research study ever done. Why is that? Because we can never study the entire universe. We always study samples, right? Can we study every one of the 4 plus million COVID patients on the planet? We can't, because that number is increasing every day. At best, we may include 200 COVID patients in our study, right? And that 200 may not be a random sample of the bigger 4 million plus people, right? Even if it is a random sample, it would still not produce the exact same results as 2 purely by chance. So random error is a big bracket which essentially speaks or accounts for chance variation in the findings. Purely by chance, not due to bias, not due to bad intent, purely by chance, you will find your study's numbers deviating from 2. Even if it's a great random sample, you might get 1.7 risk ratio instead of 2. Or you may get 2.4 instead of 2, and that is because of random error. And in epidemiology, we would never report a risk ratio or an incidence or a prevalence without providing the variance around that number. Our technique for accounting for random error is to provide a range. That's why we use terms like 95% confidence intervals. We will say the case fatality in this particular study, in this particular place for COVID-19 is 5% with the 95% confidence intervals going from 3% to 7%, right? That 3% to 7% is how we tell people that this is how we are understanding the random error in our study, okay? Smaller the study, greater the random error. This is 100% guaranteed, okay? Larger the study, smaller the random error, right? Chance becomes less and less of a headache the larger and larger the sample study is, which is why small studies are a headache. Small studies can throw results that is completely deviant from the underlying truth because small studies will not protect us from random error. Okay. And smaller the study, larger and larger and larger the confidence interval, less and less useful the study result becomes. So random error, so think of a long episcope and you have multiple filters that fall between you and the image that is blurring the true image. Think of multiple screens or tinted lenses that come between you and the true causal number that you are hunting for, and each can distort the image and take you away from the underlying true risk ratio of 2. Okay, random error can take you away from 2. Confounding can definitely take you away from 2. Confounding is exactly what I was telling you. When you look at women who take human hormone replacement therapy compared to women who don't, there is many differences between those women. If you do not adjust for the fact that women who take HRT are inherently wealthier, more likely to be white, more likely to be a non-smoker, more likely to be lean, if you do not adjust for that, you have a confounded estimate, right? Confounding is absolutely fundamental in observational studies. Confounding is much less of a deal in randomized experiments. And you will see why that is later on in this course. And then there is something called information bias. Information bias is a specific type of bias which results in a problem which we call misclassification. For example, let's say I was doing a study on COVID-19 and I'm using a PCR test, which has, say, a 70% sensitivity and a 99% specificity. I'm 100% likely to misclassify people. People with COVID might get wrongly labeled as having not COVID, and a few people without COVID will be wrongly labeled as COVID, right? This misclassification is guaranteed in this situation because there is no perfect test for COVID yet, okay? Misclassification is also possible in the exposure variable, right? Smoking can be misclassified. There are people who smoke who may not report that they are smokers, or the amount of smoking from memory could be misclassified. So it's a huge problem in EPI. And we spend a lot of time in EPI worrying about information bias or misclassification. Can you all mute your mics, please? Thank you. And then the next set of bias is what I already alluded to, selection bias. Selection bias is why did the senior surgeons pick the severest sick people to operate upon, right? That's a selection problem. By selecting to operate on the sickest people, the study sample is already skewed. And you really have to understand why is it that somebody participates in a study? Why is it that somebody chooses to take hormones? Why is that somebody volunteers to be in a trial, right? Selection bias is all about who gets into your study in the first place and why they got into your study, right? Selection bias is a huge deal. So in India, for example, if you did a survey purely basis on who volunteers through Facebook, you will get a skewed group. Who is on the Facebook in the first place? Who has a mobile phone in the first place? And why are they volunteering in the first place? All of that can skew your results to a certain group that is far away from the underlying population you're trying to get at. So whatever results you get is already impacted by that selection bias. Next, there's a bias in analysis and inference, which you learn about later on. And there's also this reporting and publication bias. Not every trial gets published. In fact, positive trials have a much greater likelihood of getting published in Lancet, New England Journal, or whatever, compared to negative trials. And if negative trials get buried, positive trials get published, then you have a publication bias problem. And you will learn about that when we talk about meta-analysis, right? And then there is also bias in how we as people use the knowledge at the end. So you see here, by the time this drama plays out, you started off with the causal risk ratio of 2, and you now down to an RR sub association. All we get out of our little study is a risk ratio for an association. That risk ratio, we will never report it as a causal risk ratio. We can only hope that it is close to the causal risk ratio, but no one single small sample study can ever claim that what they found is causal. Okay? So the risk ratio for the association could be far away numerically from the risk ratio from the causal truth that we are looking for. So this is a beautiful illustration of how many things can go wrong in an epidemiological study and how many sources of error and bias can distort the true causal effect that we are trying to look at, right? So in the end, you see a blurry patch in your episcope and you think that's the true causal image that you're going after. In reality, you may have completely missed the effect that you're looking for, right? So here is another way of saying the same thing, a skeptic's algorithm for association. So if you say vitamin D protects you from COVID-19, then the first thing we would ask is this due to chance? Is it due to chance or not due to chance, right? We're looking for random error. So when we do a p-value, for example, we're really asking, is that association between vitamin D and COVID purely a statistical fluke, right? That's why that p-value or the confidence intervals gives us some understanding of how big chance played a role in that particular finding. Smaller the study, greater the risk that the random error will not find anything. Right? There's too much noise when it's a small study and there's a lot of random error. Random error should be really seen as random noise in the data set. Right? You want to separate the signal from the noise, and the way we try to separate the signal from the noise is to do statistical tests of significance like p-value or the confidence interval. Then, if it is not due to chance, then you say, okay, vitamin D does look associated with COVID, and we've ruled out chance as an explanation. Well, then could it be due to bias, right? Selection bias, information bias. If we convince ourselves that we've not done a bad job of selecting people into the study, that the quality of information is quite good, misclassification is not a problem, then we adjust for something called confounding. Could there be another variable that explains the relationship between vitamin D and COVID? For example, are people on vitamin D more likely to not smoke? Are people taking vitamin D likely to exercise, right? We are always worried about extraneous variables that can influence the relationship between exposure and the outcome. If all of this works out okay, then we say, okay, this seems like a valid association that is holding up the test. It is not random chance, it's not selection bias, it's not information bias. We've adjusted for confounding and it is still holding up. Then maybe vitamin D is definitely associated with COVID-19. But it still doesn't mean it's causal. If it's just one study on vitamin D and COVID-19, no epidemiologist will ever say this is causal. We will say it's an association that requires replication and confirmation. And we would like that same knowledge to come from different designs. And we would also love to see a randomized trial where vitamin D is administered and then we actually show a reduction in COVID-19. That would be a very strong corroborative evidence. And so it's a long way to go before we declare the vitamin D COVID to be a causal association, right? It could be an association, but it doesn't need to be causal, right? So random error and bias. And then to make a decision on causal inference, we often use criteria called Hill's criteria. And I will talk about that in a second, right? So this is the last slide in this first lecture, just to tell you that epidemiology by no metric is perfect. Even in this pandemic, there's plenty of very poor quality studies out there, right? The problem is less with the poor quality research. The problem is more in over-interpreting poor quality research and expecting individual studies to converge to the truth so quickly. It can never happen. Causality is far away from anything in COVID-19 right now. Okay, no association in COVID-19 right now is even remotely close to being called a causal association. We have to allow studies to percolate good, bad. We have to weed out the bad, and then we have to see whether there's enough studies replicating it before we finally converge it, right? So I think this, I love this title, Epidemiologic Studies, Warts and All, are our best chance at getting at the truth. But we've got to give this a shot at maturing, right? Right now, the COVID research has not matured. That's why we are struggling to know what's associated, what's not associated, what's causal, what's not causal. And the expectation is that we will converge at the right answer very quickly. Do you folks know how many years, decades it took before we finally converged that smoking is causally associated with lung cancer? It took decades worth of research, literally hundreds of studies to finally nail that and bury that topic. Right now, nobody will ever debate that smoking causes lung cancer, but it wasn't a slam dunk. It took years worth of work before we got there. That's why if somebody says vitamin D protects you from COVID, I start laughing because we're nowhere close to that yet. And I want to see a lot more data and I want to see multiple studies. I want to see unbiased studies and I want to see randomized evidence before I buy that. Even one randomized trial is not enough for me. I want to see more than that, right? Replication is also very important. So we're far away from concluding that vitamin D protects you from COVID-19. And just to kind of sum up my concerns, there's just too much noise in this pandemic, right? Huge variability in diagnostic testing, quality of testing is variable, deliberate suppression of information. Each country is taking off at a different time point in this pandemic. No two countries are comparable here, right? Look at Brazil and Russia last month. Look at Brazil and Russia today. The epidemic has exploded in these countries, right? So if you had looked at last month data and you say, oh, Brazil is fine, Russia is fine, no longer fine this month, right? And there's more models right now and estimates than real data. And there's obviously a lot of misinformation campaigns going around, which adds to the noise. I mean, I just saw a study or paper which says 23,000 papers have come out on COVID since January. I mean, this is madness. And nobody is able to keep up with the literature. Preprints, fast track, no fact checking, not peer reviewed. Many of the studies are done by people with zero expertise in infectious diseases, epidemiology, virology, COVID 19, nothing. All sorts of random people are publishing studies on COVID right now. And it's like we've lowered all our normal scientific standards for COVID, right? Hydroxychloroquine is a beautiful example. People jumping the gun with very premature preliminary data and then just running with it, making crazy policies, tons of correlations. BCG, vitamin D, it's something else, it's something else, it's something else. It's like a whack-a-mole situation. And everybody's throwing up correlations based on, oh, this country is okay, that country is okay. But no two countries is comparable. Not in its population structure, not in its age structure, not in its rate of diagnostic testing, not in terms of socioeconomic status and other things. Very, very challenging to figure this all out. And then that's partly why I've been kind of writing papers, trying to calm us down on some areas that I understand best. And I think a lot of other people are doing something similar. But media reporting has also been very problematic in this particular pandemic. We know that in some areas, media is muzzled. Media is also COVIDized. COVIDized in the sense that this is all media is reporting right now. Everything is sensationalized, hyped up to increase clicks. Social media is amplifying everything. Correlations are presented at causal findings. And generally, media has been very uncritical. They just seem to accept every preprint, every blog post as God's truth without even challenging the underlying assumptions, right? Who wrote this model? What are the underlying assumptions? What is the denominator we are talking about? All sorts of studies are being given similar weightage in this pandemic, right? A well done study and a preprint based on a cross sectional study is getting the same kind of coverage in this particular situation. So I like this paper of promoting healthy skepticism among journalists. And that's exactly, I think, the purpose of this course, to make you all very skeptical of what you read, the news, the press release that you get, or the preprint that you're looking at. And here are all the epidemiological concepts that we think all journalists should be knowing, that we would be covering in this particular course. There's also a few good books that you can read. I think Bad Science by Ben Goldacre is one of the best that I've read, which I would recommend to all journalists to read, because he tells you how fundamentally biased and flawed many research studies are. And there's also an issue that I'm not going to cover that is also equally important, I would think. Right now in this course, I'm focusing on epidemiology. But in reality, it's more than that, right? You should also worry about conflicts of interest. Who is the researcher? Who funded the work? Is it ethically done or not? It's a whole set of additional issues that are nothing to do with epidemiology. It is to do with the whole enterprise of science, right? If, for example, all the remdesivir trials are funded by the company Gilead, you should really take that with a big, big pinch of salt, because there's plenty of empiric data that industry funded studies are invariably positive to the industry products. You almost never find an industry funded study saying our drug sucks, right? It's unheard of. There is no such thing. Industry will never ever put out studies which go against the product, which means you see a tip of an iceberg, like all the studies done on depression, primarily funded by the pharma industry. Lots of negative studies on antidepressants never ever got published. So we look at the tip of the iceberg, we look at the antidepressant studies, and they all seem to work. But you look at the massive number of negative unpublished trials on antidepressants, the whole conclusion dramatically changes. So conflicts of interest, ethics or lack of ethics are all additional issues that any good journalist should also worry about. Who funded the study? Do they have a conflict of interest? Who do they work for? Are they trying to promote some agency's opinions through their research?